Hit the subscribe button or visit us at auau.auanet.org.
Okay, we're supposed to read this information. This course utilizes audience response questions. To participate, you will need to scan the QR code located on handouts near the entrance to the meeting room or on the screen. The AUA 2023 Annual Meeting mobile app is available and is free to download. When you download the app, you will be asked for a username and password. Course materials are available on the AUA 2023 website and mobile app. Use your email that you use to register. Your password is your AUA ID. You can find it on your registration badge. General welcome and introductions. I guess is that all they wanted us to read? Or
yeah,
this as well?
I think we have to read the whole thing.
AUA policy states that all planners, authors, and presenters must disclose prior to their presentation all relevant financial relationships with any commercial interests. These disclosures are posted on the AUA's annual meeting website. For easy access, please visit www.auanet.org/annual meeting. Please remember to silence your cell phone. No photos, video, or audio recordings are permitted. Courses are selected based on evaluation results. For every course evaluation that you complete, your name will be entered into a drawing for complimentary registration for next year's conference in San Antonio, Texas. You can evaluate this session by selecting Evaluate through the credit claim process, going to the AUA 2023 mobile app, click on the CME button, or go online and click on the CME page.
Okay, so we are first going to start with the pre-test questions. And this is the agenda for the presentation today. I'll give a short introduction to genetics of urologic cancer. Dr. Maria Baker will go over the basic concept and component of genetic risk assessment. Dr. Brian Shuck will talk about the genetic evaluation for kidney and adrenal cancer and also a different model of genetic delivery. Dr. Marie Collar will talk about genetic evaluation for upper tract and bladder cancer. And finally, I will talk about genetic evaluation for prostate cancer. Dr. Maria Baker is a professor of medicine, and she's also the director of the Penn State Health Cancer Genetics at Penn State. Dr. Brian Shuck is an associate professor of urology and director of kidney cancer research program at UCLA. He's also the first mentor who got me excited and interested in genetics of urologic cancer. And Dr. Marie Carlo wears many hats. She's a medical oncologist, she's a geneticist, she's a funded researcher at Memorial Sloan Kettering, and she was my mentor when I was a fellow at Memorial Sloan Kettering.
The better mentor.
And finally, that's me. I'm an assistant professor, and I'm a urologic oncologist at Penn State. So do you have the pre-test questions? If not, we can go straight to the course material. Okay. So this is question number one, and just answer the best you can. Then hopefully by the time we complete this course, some of these concepts will be more familiar to you. Question one, based on the INTERCEPT study, what percentage of solid tumor cancer diagnosis are due to an underlying germline mutations? Okay. Nobody have cast any vote yet.
Do we need that QR code or something?
Can you come back to the QR code, please?
Perfect.
Yeah.
There you go.
There you go. Okay. Did everybody get the QR code? Okay, now go back to the question, please. Question one.
Let's go back one slide.
Uh,
Yeah. Here we go. Even though there's not many people
Okay.
here, there are millions of people at home.
Great. Question number 2. Which of the following patient with a history of adrenal tumor should be referred for genetic evaluation?
I think the question is wrong.
Okay. Number 3. Belzutifan is approved for medical treatment of patients with kidney cancer associated with which of the following genetic alteration? A, FH, B, VHL, C, VHL germline or somatic, and D, MET mutation. Question 4. Which of the following is a phenotype associated with Lynch syndrome? A, kidney cancer, B, mismatch repair deficient cancer, C, microsatellite stable colon cancer, and D, early onset uterine fibroid.
It's not loading.
Okay. Question 5. Which of the following federal laws protect against both health insurance and employment discrimination? A, HIPAA, B, GINA, C, the ACA, and D, ADA. We have 3 more questions. Question 6. Which of the following found on prostate tumor sequencing is a biomarker for pembrolizumab in a patient with metastatic prostate cancer? A, microsatellite instability, B, BRCA2 loss, C, low tumor mutation burden, D, TP53 mutation. Okay. Question 7. A 75-year-old man prostate tumor test saw a BRCA2 loss and a TP53 R2A3C pathogenic variant. Without knowing more, which is the best description of these variants? A, these variants are germline specific. B, these variants are tumor specific. C, these variants are in the tumor but maybe in the germline. And D, these variants are in the germline and maybe in the tumor. And last question. A 43-year-old otherwise healthy woman with a 3-centimeter renal mass underwent a partial nephrectomy. The pathology was PT1A clear cell renal cell carcinoma, grade 3. Her family history is significant for her father with localized prostate cancer diagnosed at 65, treated with surgery, and her sister with clear cell renal cell carcinoma diagnosed at 50 years old. She underwent telehealth genetic testing, counseling, and consented to testing. With genetic tests should you order? A VHL single gene test, B, a kidney cancer panel test, C, large 58 gene cancer predisposition panel test, and D, she did not meet genetic testing criteria.
Why is that reloading?
Okay, we can go back to the presentation slide, please. And if you have any question along the way, you can answer it, raise your hand. You don't have to tap it in the chart here. So first, just an overview of what genetics versus genomics is. And, we see these terms thrown around a lot, and sometimes they use interchangeably. But, there are subtle differences. So genetics is the study of a specific single genes and the function and composition of the gene. And usually genetics refer to hereditary. The germline genetics versus genomics refer to a complete set of genome in an individual and how the genetic information interact with each other and their environment. Genomic evaluation can also refer to tumor environment and how it interact with the host interaction. Why should urologists care about genetics of urologic cancer? Well, it turned out that the heredity of urologic cancer is exceptionally high, and in fact, much higher than colorectal cancer, which is about 15%. So there is a large study based on the cancer risk in monozygotic versus dizygotic twins of an individual with cancer diagnosis. And from that, we were able to deduce that the heredity of prostate cancer is almost 60%. Testis cancer is 37%, kidney is 38%, and bladder is lowest, but it's still very high, comparable to breast cancer at 30%. And if a germline mutation is found in an individual with urologic cancer, there's a lot of clinical actionability based on that information. The first is that their family member, even those without a cancer diagnosis, can qualify for genetic testing, usually covered by insurance and also genetic company for free. Second, there are prophylactic surgery, and Angelina Jolie probably is the most well-known example of someone who underwent prophylactic mastectomy and oophorectomy to mitigate the risk of being a BRCA1 germline carrier. There's increased cancer surveillance. Patients with a germline mutation in a cancer predisposition gene, such as a BRCA1 or 2 mutation, are at risk of developing additional cancer diagnosis. So they qualify for enhanced cancer surveillance. So as you can see here, normal patient would get mammogram, but someone with a BRCA germline mutation would qualify for breast MRI, and certain breast tumor may be missed on standard mammogram compared to MRI. Certain germline mutations, there may be chemopreventions. So tamoxifen is being investigated for breast cancer prophylaxis in an individual with BRCA mutation versus in Lynch syndrome. Aspirin have been shown to be effective in reducing the risk of colorectal cancer. And if we miss patients at early stages of their cancer, in advanced stages, there are targeted therapy, including BOP inhibitor in BRCA1 and 2 carrier versus immunotherapy in patients with Lynch syndrome. And these medication will be covered later in our talk. So I'm going to turn this over to Dr. Maria Baker, who will talk about component of genetic counseling and evaluation.
Thank you. So I'll start us off by talking about genetic counseling and testing for hereditary GU cancer. During my presentation, I'll review the traditional model of genetic counseling and testing for hereditary cancer and why it may not be sustainable given the expanding indications for genetic testing. I'll discuss the evolution of multi-gene panel testing, including the pros and cons using case examples, and introduced alternative service delivery models to address challenges with access to cancer genetic testing. So, although there are some cancer susceptibility genes that were discovered prior to 1990, for example, the retinoblastoma gene, really the field of clinical cancer genetics evolved as a result of the Human Genome Project, which started in 1990 and was completed in 2003, somewhat surprisingly ahead of schedule and under budget for a federally funded program. For example, there were a variety of genes that were discovered during that decade following the beginning of the Human Genome Project. The mismatch repair genes involved in Lynch syndrome were discovered between 1993 and 1995. They're responsible for the most common hereditary cause of colorectal and endometrial cancer. Importantly, for the purposes of our course today, Lynch syndrome also increases the risk for GU cancers, including upper tract urothelial carcinoma involving the kidneys and the ureters, as well as cancer of the bladder and the prostate. In addition, we have the discovery of the BRCA1 and 2 genes in 1994 and 1995, and clinical testing became available for those genes in 1996. They represent the most common hereditary cause for breast and ovarian cancer, but of importance in our course today, they do increase the risk of prostate cancer, and there's a tendency towards more aggressive prostate cancer, which plays into the criteria for eligibility for genetic testing. In addition, these genes increase the risk for pancreatic cancer, male breast cancer, as well as BRCA2 has been associated with melanoma. So the traditional approach to cancer genetic testing, which has been going on since the 1990s when these genes were discovered, involved a sequential approach where we would test for one gene or condition that was highest on our differential. And it was very important that we got pathology reports to verify the accuracy of the information, because we were going to create that differential diagnosis and order a test that at the time was thousands of dollars. If the testing came back negative, then we would consider reflexing to the next most likely gene or condition, spending another several $1,000s. So there are potential downsides to this sequential approach. It's very time intensive. There's the potential to develop testing fatigue, not only for the provider, but the patient as well, and it's also very costly. But fortunately, in 2012, there was the introduction of the next generation sequencing panels, or multi-gene panel tests. Seemingly overnight, the way we practice changed tremendously. So with the traditional approach, rather than using Sanger sequencing, which involves generating one sequence read per base pair in both the forward and reverse direction, with next generation sequencing, we're doing massively parallel sequencing to generate multiple sequence reads per base pair, followed by alignment of those reads for the purpose of variant calling. In this sample hereditary cancer panel, on the left-hand side, you can see that there are a number of different cancer susceptibility genes, and across the top, you can see that these genes predispose to a variety of different cancers. This is what we call a pan-cancer panel, because it doesn't focus on genes that predispose to just, one major specific type of cancer, but it encompasses a variety of different cancer susceptibility conditions that include a number of different types of cancers. So the laboratories each developed their own approach to creating these next generation sequencing panels. The pan-cancer panel, which I already mentioned to you, where there's really no flexibility to add genes or remove genes. The cancer-focused panels, for example, a panel focusing specifically on major breast cancer susceptibility genes. And then you could choose to make that panel larger or smaller, depending on whether the patient felt comfortable with including genes that don't currently have any guidelines associated with them if a mutation were found. So if the patient's not comfortable with not having guidelines, once a mutation is found, you would focus on a guideline-focused panel where they're guaranteed to have, for example, NCCN guidelines developed. Then some labs allowed us to customize our panel to pick our own genes out of a selection of genes that they offer. Many of these labs introduced the ability to reflex to a larger panel at no additional charge for a defined period of time, and some of them developed stat panels where we could get test results in as little as 5 to 7 days if, for example, surgery was pending and we wanted the genetic test results to inform surgical decision-making. Now, in the traditional role of genetic counselors, we would get involved up front. We would educate the patient about the risks, benefits, and limitations of genetic testing. We would coordinate that testing and then meet with that patient in person on the back end when the results became available. But this is rapidly becoming unsustainable because of the expanding indications for genetic testing. And I'm not trying to put myself out of a job, but it's just the reality of the situation. There aren't enough genetics providers to be able to accommodate all of this germline testing. And so the genetic counselor, if they are involved in that traditional upfront model, they're going to start by eliciting the personal and family history, drawing at a minimum a 3-generation family pedigree, using standardized pedigree nomenclature with squares representing the males, circles representing the females, indicating their sex assigned at birth. But most recently, we actually modified these pedigree nomenclature so that the squares and circles and now the diamonds actually represent the individual's gender identity and then indicate the sex assigned at birth by including assigned female at birth or assigned male at birth underneath. Once the pedigree is drawn, the genetic counselor would evaluate what they felt was most likely as the explanation for the clustering of cancer in the family. Does it look like these cancers are independent cancers and thus sporadic? Does it look like there could be some familial clustering where there are multiple factors involved, both genetic and environmental risk factors, lifestyle risk factors? The genetic factors would consist of single nucleotide polymorphisms or SNPs that incrementally but collectively can increase or decrease a person's risk to develop cancer. As opposed to with hereditary cancer, we're looking for a mutation in a single cancer susceptibility gene that may be the major driving force, not that there aren't other factors involved, but the major driving force in why that individual developed cancer. The genetic counselors use a variety of risk assessment models to estimate the likelihood of carrying a mutation in one of these cancer susceptibility genes. I've included here the PREM5 model, which helps to estimate the likelihood that an individual would have one of the Lynch mutations. That model incorporates information about relatives who have Lynch-associated cancers, the patient and whether or not they have Lynch-associated cancers, the ages at diagnosis, and how closely related those individuals are, to then generate a risk estimate. If the risk estimate is 2.5% or greater, that patient should consider genetic testing. If the risk estimate is 5% or greater, it's recommended that they pursue genetic testing. There's a subtle difference there. In addition to the risk assessment models, we use a number of professional society guidelines to help determine whether a patient meets criteria to pursue genetic testing. So I've included here the hereditary renal cell carcinoma guidelines. If you look at the top, you can see, for example, that a patient with renal cancer at 46 years of age or younger would meet criteria regardless of any additional family history, if they have bilateral or multifocal tumors, or if they have a close relative in addition to their diagnosis with renal cancer. And then there are some family history criteria, there's some histology criteria. It can be quite complex, and you see, I mean, you can't memorize these, and they're changing all the time. If you notice here, this is version 4 of 2023, and we're only in April. We also discussed the 3 possible test results that we could find a mutation or what we call a pathogenic or likely pathogenic variant, which may inform medical management. We could get a completely normal test result, in which case medical management would depend on the personal and family history that exists today. And we definitely need to prepare patients for the possibility that the laboratory could identify 1 or more variants of uncertain significance, what I call a gray answer, that importantly does not influence medical management. I tell patients not to worry about these VUSs because they're very common. About 25 to 30% of patients who do large panels of genes will get at least 1 gray answer, and we know based on experience that 90% of them end up being downgraded to normal over time. So these should not influence medical management decisions. We also discuss what federal protections are available to protect against genetic discrimination, and we feel pretty comfortable about these protections when it comes to our health insurance and our employment. Notice that GINA not only protects against health insurance discrimination, but also employment discrimination. But importantly, we don't have any federal laws that protect against genetic discrimination when it comes to life insurance, long-term care, and disability insurance. So it's important for patients to appreciate before they pursue testing that if a mutation is found, it could make it more challenging, not only for them but their relatives to get private life insurance. But on the other hand, this genetic information can be life-saving in that if we identify a genetic predisposition, it can inform medical management so that we have an opportunity to prevent cancer or detect it at an earlier stage. So each patient has to decide for themselves what drives their decision-making. Once all of those required elements of pre-test genetic counseling are completed, we can then move forward with the testing if elected by the patient, either by drawing a blood sample or getting a saliva or buccal swab sample, or if the patient has undergone an allogeneic stem cell transplant, we need to get another tissue source, usually a skin punch biopsy, where we'll then need to culture those skin fibroblasts, then do the DNA extraction, and then proceed to the testing. Unfortunately, that creates a time lag of a good 2 or 3 weeks to culture the cells, so it's not really a good situation when you need to get those results on a stat basis. So part of the challenge in meeting with patients and coordinating genetic testing is to figure out which lab is the right lab to send the sample to and which panel, how many genes are appropriate to include on that panel. And it's so really complicated and difficult to stay up to date on all these laboratories, policies, and procedures that I can tell you we have a whole spreadsheet that we keep track of all the different genetics labs and what their current policies are. So I've included 2 fictional labs to illustrate my point today. And then we look at a number of different patient-specific parameters. Does the patient have insurance? If they do have insurance, what type of insurance? So you can see here Lab A has a policy that that patient is guaranteed 0 out-of-pocket if they meet NCCN guidelines and their insurance company doesn't pay for the test, for whatever fluke of a reason that they're not yet following NCCN guidelines. Whereas Laboratory B offers a 0 out-of-pocket for specific types of insurances like Medicare or medical assistance if the insurance does not cover. So I can give patients peace of mind that they will not get a bill even if the insurance company is not going to cover the test. And we know Medicare is not set up to be preventative, so think of the situation where you have a daughter who was just identified to have a BRCA2 mutation, parents are of Medicare age, we need to figure out which side of the family the mutation came from, but Medicare will not cover the genetic test for those parents to eliminate 1/2 of the family from having to be concerned about that BRCA2 mutation. So there's currently a federal bill called the Reducing Hereditary Cancer Act. Wasserman Schultz is the one that's moving that forward to try to eliminate that financial barrier for Medicare patients. Many of these labs have a patient assistance program. Some labs are more generous than other. Lab A actually goes up to 600% of the federal poverty level based on household income and family size. And if they make under that 600% level, 6 times the federal poverty level, they will drop the cost of the test to $100 out of pocket. So if I'm, for example, working with a patient that I know has a large unmet deductible or co-insurance, I switch over to that lab because I know then I can get the test for $100 as opposed to maybe sticking with another lab where I know they're going to get a price of about $200. Like an 80% discount off of a $1,000 contracted rate ends up being $200. There are some self-pay options, $250 out of pocket. They take a test that's billed at thousands of dollars. The contracted rate's roughly $750 to $1,000. But if the patient's paying self-pay, it drops down to $250 to recoup the cost of the reagents and maybe make a little bit of profit or take a hit. Each of these labs have different turnaround times for their stat panels, and then it depends whether or not we're adding RNA analysis to the DNA testing. RNA analysis is not yet standard of care, but it can ever so slightly make the testing more accurate or sensitive. It can help clarify splice site variants so that the patient never gets a VUS result, and they can clarify, looking at alternative splice transcripts, whether there's any normal RNA transcripts present, and then use that information to determine if it's a normal variant, if it's still a VUS, or if it's actually pathogenic. In addition, RNA analysis can, in rare situations, identify a deep intronic mutation that would be missed by DNA alone. So if we can get RNA, it's great, but it's not yet standard of care. If I want to get a gene that a lab doesn't offer RNA for, but I need that gene because of their diagnosis, then I forego the RNA and go for the panel that allows me to get that additional gene. Many of these labs have free reflex testing where you can upgrade your size of your panel within a defined period of time. That situation is when, for example, they don't find a mutation. Maybe the patient didn't feel comfortable doing a large panel. They tempted the waters, the fate. They feel a little bit more comfortable, and it came back negative, and now they're ready to expand their panel. Or possibly additional family history information became available in the meantime, and the genes that you would want to evaluate based on that new information were not included on the original panel. So for anywhere from 3 to 5 months, you can upgrade that panel for free. And then some of these labs also offer free cascade testing. It's important to know the policy of the lab. Some of the labs will only offer free single-site testing for the specific mutation. Some of the labs will look at the whole gene, but only the gene in which the familial mutation's already been identified. And some labs will actually offer free panel testing of the same size that the original relative pursued. And that's helpful when, for example, there could be other family history on the other side of the family where the mutation did not come from. You don't want to leave that side of the family unexplained for a sibling because it's possible they could have inherited a mutation from that side of the family that the original individual did not. So you can't get false reassurance. You need to order the proper test for the person in front of you. So sometimes it might seem like bait and switch. We tell these patients, oh, your relatives can get free testing. But when we meet with them and evaluate the family pedigree, the better approach is for them to do a panel. And then when the test results come in the past we used to meet in person to go over the results. That was our policy, but we've forgone that a long time ago. We just have too many referrals, and they're taking those follow-up appointments, unfortunately, are making it more difficult to accommodate the new referrals. So we disclose all results out over the telephone. And then if it's positive, then we'll bring them back in for an in-person appointment or a Zoom appointment if that's what they prefer. We then use a number of different tools to help educate about the associated risks for cancer, the lifetime risks. This particular tool called Ask2Me, you can input the age of the patient, whether they're male or female, the specific gene that has the mutation, and it will generate a number of tables and bar graphs to illustrate that lifetime risk for cancer, as well as how they travel through that risk over time in comparison to someone in the general population. And then we let patients know what research opportunities they might be available to participate in, not only to further scientific knowledge, but also, for example, what I particularly like about the Inherited Cancer Registry is if a patient does participate in that registry, it guarantees that they're going to get a newsletter twice a year that updates them about new developments in clinical cancer genetics. And then we put them in touch with various support resources, and in the interest of time, I'm not going to go into detail about those, but know that they're available. It's a great way for patients to stay educated, to meet other families dealing with similar issues, and to learn a lot. So these next generation sequencing panels certainly have a lot of positive attributes. We can study multiple cancer susceptibility genes at the same time in a more cost-efficient manner. It also increases the likelihood that we could find more than one hereditary cancer syndrome in a family should more than one predisposition exist. And so I'm not sure how well these project, whether you can see these pedigrees or not. But in this particular family, the proband, who's indicated by the arrow, was referred because he was diagnosed with an upper tract urothelial carcinoma. And when you look at the family history, you can see that the maternal side of the family does meet criteria to offer testing for Lynch syndrome. However, given the other types of cancers in the family, the breast cancer as well, it really is important that we not focus in specifically on Lynch syndrome, but we offer a whole panel of cancer susceptibility genes. And this individual did end up having a large deletion involving EpCAM, which is upstream of MSH2, and extending into the MSH2 gene, documenting his diagnosis of Lynch syndrome. I then met with his brother, who was diagnosed with a clear cell renal cell carcinoma with sarcomatoid features, and I explained to that brother that although we typically would only offer testing for that known mutation that's been identified, given that that type of renal cancer is not really classic for Lynch syndrome, and because of the family history of various cancers, it really would be better to offer him a large panel. And as it turns out, he did not have Lynch syndrome like his brother, but he did have a low penetrance pathogenic variant for CHEK2. Subsequent testing on the mother did confirm that both of those mutations originated from her side of the family. And in this family, this patient was diagnosed with colorectal cancer as a result of our universal screening program at Penn State Health. The tumor demonstrated absent MLH1 and PMS2 expression. There was no BRAF mutation to provide a possible sporadic explanation for the abnormal IHC expression. In meeting with the patient, she elected to do testing initially of MLH1 and PMS2 only. It came back normal, but given the family history of various cancers, she did then reflex up to a panel, and she was found to have not only an ATM mutation, but also a BRCA2 mutation. Interestingly, although I didn't know it at the time, her oncologist had ordered tumor profiling, and you can clearly see both of those germline mutations on the tumor profiling report. So this is another reason why we might get referrals. Many of these genes, if they do have clinical relevance and importance, if present in the germline, those patients should be referred for germline testing. Now, some of these labs are doing both tumor and germline at the same time, so in picking your labs and where you're sending samples, you would want to take that into account if you would rather the one-stop approach. The next generation sequencing panels are all not good. There are some situations that arise. There's an increased likelihood of finding one or more variants of uncertain significance simply because of the sheer size of these panels, the fact that we might include some moderate and low risk susceptibility genes that maybe we haven't been analyzing as long and haven't had as much time to figure out what those VUSs mean. In addition, although it's not mentioned on this slide, if we're testing someone who's not Western, Northern European, Caucasian, we do, give them some advanced warning that they may have a higher chance of having VUSs identified. Another potential downside of these next generation sequencing panels, and honestly for genetic testing in general, is that there can be conflicting interpretations of these variants between laboratories and even within laboratories over time. So this particular patient I initially met with in 2012. She had a clinical diagnosis of von Hippel-Lindau syndrome because of cerebellar hemangioblastoma. She also had a diagnosis of renal cancer, and we tested her for just VHL at the time. That was right around the time that we were switching over to panels, but not quite yet. And she did have a variant in VHL, which the laboratory classified as a VUS, but likely pathogenic. They just couldn't decide, so they decided to call it out as both. 10 years later, she was diagnosed with breast cancer. She was referred on a stat basis. The focus was a breast cancer stat panel to inform surgical decision-making. It went to a different lab. That lab classified that same variant, which they also saw as a VUS. Realizing that I really hadn't, although I had provided them with the report from the initial lab, I had not provided them with all the phenotypic information related to VHL. So I contacted that second lab, Lab B, and said, hey, by the way, here are all her VHL features. Does that change your interpretation of the variant? They then upgraded the variant to likely pathogenic. In the meantime, I contacted the first lab from 2012 and asked them for an updated interpretation of the variant, and they downgraded it to a straight VUS. So I think what this case illustrates is that, you know, the hard part of this testing is not the sequencing. That's the easy part. It's the interpretation of these variants that is very challenging. And when we have situations like this where multiple labs are saying different things and even the laboratories themselves are changing their interpretations over time, it really undermines the confidence that we have in these laboratories. But they have a hard job to perform. In addition, the cancer risks may not be well defined for some of these genes. We may not know the spectrum of cancers or the lifetime risks to help that person make medical management decisions. Guidelines might not be developed. We might get unexpected findings. For example, we might find a CDH1 mutation in a patient that has no family history of gastric cancer or lobular breast cancer, and yet we're going to ask that patient to make a decision about whether or not they should have a prophylactic gastrectomy starting at 18 years of age when there's no family history of gastric cancer. We also can get secondary findings. We may find out that a patient is a carrier for a recessive disorder because these genes are on the panel. If they're present in a double dose, they do increase the risk for cancer. And sometimes patients may have a harder time wrestling with that result because it has reproductive implications, potentially for their children who may be of reproductive age, where if the adult child has that mutation, they may want to have their partner tested before entering into a pregnancy to see if they're at risk for that recessive disorder. And then the downright ugly, where we have likely pathogenic variants that are downgraded to a VUS after the patient pursues prophylactic surgery. And I have been in this situation 3 times in rather quick succession from one laboratory, which I think they got caught in the crossfire. They probably are still a good laboratory, but I stopped using them as a result. 2 of the patients had prophylactic BSOs, and the variant was downgraded to a VUS, not at increased risk for ovarian cancer, and one of these patients pursued a prophylactic bilateral mastectomy. Her testing was done because of a personal and family history of renal cancer. There was no family history of breast cancer. She pursued prophylactic surgery despite no family history, and then the variant was downgraded to a VUS. That doesn't mean it won't be upgraded again, but for right now, it's sitting at a VUS. Fortunately, for all 3 of these patients, they were actually still happy with their decisions, but this is the situation we can find ourselves in. NCCN has developed prostate cancer guidelines, which I'm sure will be discussed by other individuals. I'm not going to go into a lot of detail other than to say every patient with high risk, very high risk, regional metastatic prostate cancer, regardless of any additional family history, would meet criteria. I'm going to skip over this. And the INTERCEPT study, one of your pre-course questions, this recent study out of the Mayo Clinic found that 1 out of 8 patients, approximately 12 to 13% of patients with a solid tumor diagnosis had a germline mutation. Interestingly, 48% of them would not have qualified for testing based on NCCN guidelines. And interestingly, nearly a third of these patients who had a mutation in a high cancer susceptibility gene had their modification to their surgery, their chemo, their immunotherapy, or they were enrolled in a clinical trial based on that genetic test result. So this study starts to pave the way for the introduction of universal germline genetic testing. And there's no way that the qualified genetics providers across the country can handle that onset of cases. So the genetic testing is going to transition to point of care in the clinic where you're all located to coordinate the testing, to provide some form of education up front, to order the testing, and then to refer to the genetic counselor on the back end if a mutation is found. So to try to bridge the gap until more of these primary care and specialty providers take on ordering the testing themselves, genetic counselors have tried a number of alternative service delivery models, including group education counseling, disclosure of results over the phone, and now looking into flipping the model where we provide videos or brochures or even chatbots to replace our education, provide the education up front, and then the genetic counselor meets with the patient on the back end if they have a mutation. So in summary, although the majority of cancer is still considered to be sporadic, a growing number of cancers are identified to have a hereditary component using multi-gene next-generation sequencing panels. Indications for cancer genetic testing are expanding and may soon give way to universal germline genetic testing. Development of alternative service delivery models which leverage the time of genetic counselors may help to address the growing access issues regarding these services. Thank you.
Okay, so I'm covering a couple different areas, and I'll just kind of expand upon that alternative models and share also my experience. We'll just skip over these, running a little bit behind. But alternative models, as discussed, we have a lot of challenges. And when we're talking about whether someone should get tested, we first have to understand, do they have personal history? Do we have a result that can be interpreted? And do we have something that can influence medical management? And ASCO has usually, for the past several iterations of the guidelines, says that we should have informed consent for germline testing, which is a challenge because it's not just a blood test, and a provider who has no experience shouldn't just order their in vitae panel because they can get into trouble. Patients need to have evaluation. They need to have pre-test counseling. We need to know what test to order. We also know how to interpret the test, or we can make significant errors. And then obviously getting insurance coverage. When I entered UCLA, a lot of providers were just ordering their own testing, and I used to be at Yale, and they had a whole series of patients who had mastectomies, oophorectomies for VUSs, and that is just horrible if patients had inappropriate interpretation. So the problem is there's a lot of challenges to getting appropriate counseling. We talked about that some insurances don't reimburse. Medicare doesn't actually recognize counselors as providers, which is really outrageous. And hopefully that'll change with this bill in Congress. But it's been introduced before, and it hasn't gotten anywhere in other administrations. So this actually, if you have a practice and you want to hire your own genetic counselor, this obviously could be cost that you would eat. And genetic counselors at some centers, when I was at Yale, I had 13 counselors, and I was in clinic with them in a comprehensive program. I moved to UCLA, we have 3 counselors for the whole institution, and that was like 4 or 6 months wait for some things. So it is something very challenging at some centers. And then testing that is done sometimes without counseling, like such as tumor profiling, that could raise a whole can of worms. And things are rapidly expanding. I would argue that no busy urologic physician should have the time to be familiar with all these complex situations. So again, access is a barrier. There is telehealth, which has allowed, people from afar to actually reach your internal counselors. And we have, our internal counselors reach out to people who don't want to travel 2 or 3 hours. But there are telehealth companies, and I've worked with several of these ones, Genome Health, Informed DNA, My Gene Counsel. When we actually got it a long wait, we actually would supplement our internal counselors with these systems. And they offer, a video platform. They arrange blood draws or saliva draws to go to your home. And then sometimes they entice with potentially free post-test counseling, so patients could potentially save money using their lab. Now, just some methods. Everyone's familiar with the counselor-based, where you refer to the counselor and the counselor will arrange the pre-test counseling and post-test counseling. But we mentioned there's other things such as provider-initiated. You could learn, and there's some courses like the City of Hope course, which I'm faculty on, where you can potentially do good pre-test counseling, learn to make a pedigree, and then ordering the test, but then refer to a counselor on the back end. A provider-run clinic, I would really argue that really should not be done in this era unless someone is a clinical geneticist or really has full-time access to really understand all the interpretation and what should be done based on the post-test results. But then group-based, we've done counseling where patients come and they have a group session for like a common group of men with prostate cancer. That is less individualized, and unfortunately you can't really make pedigrees when you're in a group setting. And then the video-based, we have point-of-care prostate and pancreatic cancer. When someone would clearly meet NCCN guidelines, you can watch a video. If you guys talk to Veda Giri, who's now at Yale, or Raul Concepcion, who he set up his own video-based services, something like that is feasible to try to do pre-test counseling. So this is a work from Veda, who used to be at Jefferson's, now at Yale, where they did a randomized type of approach of video versus a normal genetic counselor pre-test evaluation, and they show there was similar kind of satisfaction. I would say for things like kidney or adrenal, where you have to actually show that it is going to be something that is going to be covered by like NCCN guidelines, this may not be that feasible for reimbursement. I would just show you what I did at UCLA, where we had a very, we didn't have enough counselors. So we partnered. We actually had patients in our clinic. We would refer to a telehealth company, but that was done in our clinic, and patients would have video counseling. We had their blood drawn, and then the post-test counseling was done either by, if they were negative, they had a nice video from me telling them, the results, and if it was positive, they meet with a genetic counselor, try to save some money, and it was very, very efficient. We're writing this up. So just going over, moving forward to adrenal and renal, I'll just first touch on the adrenal syndromes. We basically split patients up into the chromaffin tumors, which are the ones coming from the adrenal medulla, the PHIOs and the paragangliomas, and then the adrenal cortical coming from the cortex. For our PHIOs, they're rare. They're 1,500 to 2,000 cases a year. They're about 5% of incidentalomas, and about 1 in every 5,000 patients who comes in with hypertension. Some of these are metastatic, and unfortunately, you don't know they're metastatic until they spread. A lot of these are metabolically active, and we do recommend germline testing for all patients with the pheochromocytoma, as 30 to 40% have germline alterations. Everyone's familiar with this textbook surgical recall, which has been wrong for the past 20 years. It says 10% are genetic, but it's about 40% now. Now, the ones that come usually, they used to be called extra-adrenal PHIOs, but this name has changed to a paraganglioma, just to confuse everyone. But they're the same type of tumor. But these are about 150 to 500 cases a year. 80% of these occur in the abdomen and pelvis, but a lot of them also occur in the neck. And 1 in 2,000 bladder tumors actually will have be a paraganglioma. And this is something we see called micturition syncope, where patients will void and they'll end up having symptoms. These can be functionally significant. The ones in the neck are parasympathetic; they're not active. The ones in the abdomen are more sympathetic, and they are more secretory. About 30% of these can be malignant, and about 60% of these actually have a germline alteration. A lot of these are in the SDH family, these patients should all get referred for genetic testing. And just a paper we wrote a couple years ago with Dr. Linehan, we just kind of mapped out all the pathways, and these kind of all kind of have overlapping pathways. A lot of these are tumor suppressors, but some are actually oncogenes. Now, just a nice table. This is a table summarizing them. They all differ a little bit in their risk of abdominal versus head and neck, malignant versus benign. I'll just tell you that when you hear the word SDHB, B is for bad. And that is something which usually you worry about malignant potential. And SDHD, you worry about neck. Now, adrenal cortical cancer, this is something which most people are not familiar that could have a genetic predisposition, and these are rare, 200 to 500 cases a year in the United States, and about 5 or 10% of these cases are occurring in children. These are large tumors, that's why we have size criteria to resect. About 60% are secretory, and then a lot of these patients, over half, are advanced stage, and the prognosis is really bad. But about 10 to 15% of cases may be linked to a germline predisposition, and early identification potentially could save lives. So first things I would tell you is that any child with adrenal cortical carcinoma should get referred. There are things like Beckwith-Weidman or hemihypertrophy or Lee-Fraumeni. About 50% of the children do have a genetic predisposition. And then I will tell you that some patients, there's a really fascinating founder mutation. Just in Brazil 2 weeks ago and talked to their geneticists there. There's a founder mutation in P53 called R337, and we'll go through it later. But some of these patients, if they're Brazilian, they may actually know that they have family members with this, or other patients who might know they have Lynch syndrome could get found with adrenal cortical tumors. So many experts, including our good friend Tobias Carling at Michigan, feels that every patient should get genetic testing. I'll say that I believe, and a lot of people believe, that every patient should at least have genetic risk assessment, meaning they should be considered, look at their family history. Do they have maybe at risk for Lee-Fraumeni or Lynch syndrome? I don't think every patient must get genetic testing, but you should at least be thoughtful when you see these patients, and when in doubt, I think you should refer. Now, this about that Brazilian variant, super fascinating. 1 in 300 people in southern Brazil actually have this TP53 variant. I've actually seen 2 Brazilian patients in my practice, and I screened them and I found lesions, and we actually resected them, and they were kind of in that gray area. There were 3-centimeter tumors, and you wouldn't normally resect, but they were actually tumors. And there's actually a second variant, which is called XAF1, a paper in Science last year, which is a modifying gene which affects risk here. But 1 in 300 Brazilians in southern Brazil may be at risk, and they have like a Lee-Fraumeni type syndrome. Just looking at the patients who can give ACCs, those genes, again, Lynch syndrome and Lee-Fraumeni are the biggest risk factors. These other ones are kind of loosely associated, not really great evidence. MEN1, FAP, Beckwith-Weidman, NF1, those I would say are kind of not really strongly linked, but they've seen maybe a slight enrichment in cases. Now, moving on to kidney, we've long said 2 to 8% of kidney cancers are genetic or hereditary. As a fellow under Dr. Linehan, I try to figure out, well, where did that come from? And it came from him citing his paper, then citing his paper, then citing his paper, and it was really not supported by any evidence. Just you say something long enough, people will believe you. But about 15 conditions now, 15 genes are associated with RCC, and there's a really strong inheritance pattern. If you look at like twin studies, as Hong mentioned, and registries. There's a lot of Mark Purdue, who is an epidemiologist, has done a lot of things on risk alleles, and they may be moving to a polygenic score like prostate cancer, and his work that is actually emerging that you potentially have a lot of enrichment looking at these multiple genes. And the surgical and systemic approach may be dictated by the presence of some of these hereditary genes. Now, unlike the adrenal lesions, if you refer to everything to your genetic counselor, they'll probably not be too upset with you, but there are 35 times more kidney tumors than adrenal. So you have to be selective. You can't just refer everything, or your genetic counselor's wait will go from 2 months to 2 years. And your genetic counselor will probably be very angry with you, I'm sure. Now, a lot of this has come from, my mentor, Dr. Linehan, a lot of other people who, were in this area. The way they mapped all these genes, they flew a lot of patients to the NIH on your taxpayer dollar and started doing sequencing of the affected and unaffected family members. But a lot of these cases, when you see clinically, they may be hiding and they be not so apparent. And if you don't look for it, you won't find it. And when we have a wonderful, 20 different WHO recognized subtypes, really only 2 of them are really listed here that obviously you'd think to have a strong genetic predisposition. We have now a category called SDH deficient renal cell or FH deficient renal cell, but that only accounts for 2 of the conditions. A lot of the ones are going to be in this family. These are cases that you'd think are sporadic, but if you actually did germline testing, you might find some genes in these. So clear cell, VHL, SDHC, BAP1, these are, ones that you see. We don't call things type 1 or type 2 anymore, but the ones that are type 1, formerly known, the artist formerly known as type 1, MET, P10, I've actually also seen some BAP1. So some of these genetic forms can resemble the hereditary forms. I've seen a lot of tuberous sclerosis patients recently that have this low-grade oncocytic with a germline mutation. So again, these subtypes, it doesn't scream and say this is hereditary unless you're in that SDH deficient or the FH deficient. So we have very well-defined syndromes which differ by incidence and their other manifestations. Pretty much every single one of these will have other features other than this crazy hereditary papillary renal cell, which is an oncogene. It's in every cell in the body, but for some reason they only get kidney cancer. It's an activated, the MET receptor, and they only get kidney cancer. I don't know why. But these conditions are actually more common than you'd think, and I'll explain why. We actually, when I was in New Haven, everyone said, you can't study HLRCC leaving the NIH. It's so rare. It's 1 in 200,000. Well, New Haven's a city of 130,000 people, and I had 30 families in Connecticut in a matter of 5 years. So we said, this is pretty common. So we looked at exact 1,000 genomes, and lo and behold, a database from Invitae, we think probably this is about 1 in 2,000 people. And you might think I'm crazy, but Geisinger, which is a very amazing health system where they've done a ton of sequencing, and they actually looked at folliculin loss of function. Folliculin causes Birt-Hogg-Dubé. They think 1 in 3,500 people are walking around with Birt-Hogg-Dubé syndrome. Again, if you don't image, how do you know you have a lung cyst? Do you know how many people don't go to the doctor because they have a funny looking bump on the side of their nose? So these conditions are more common, and if you don't look for it, you don't find it. Now, if you look at what's the incidence in patients who actually have gone for germline testing, these are many series, one from Marie, and another one I think Hong was on. Basically, if you send patients who are early onset bilateral, multifocal, you potentially will be enriched. But as you see here, these enriched cohorts, about maybe 4 to 6% will have a hereditary gene associated with kidney cancer. But if you look at an expanded panel, besides seeing variants of unknown significance, you might find a lot of other genes. I have a lot of patients who've been found with BRCA1, BRCA2. Well, it's maybe not associated with their kidney cancer. It's because there may be an Ashkenazi Jewish a patient. So these enriched cohorts, they're definitely a little bit biased. But we've also seen some of the other genes like CHEK2. I'd say Maria has a paper really giving great evidence that CHEK2 is really a kidney cancer gene, and some of these other ones are not clear. There's a cohort from UK which looks at a consecutive series of a couple thousand patients, and they think it's probably more in that 4 to 6 range, and about maybe 3% of all comers are associated with hereditary kidney cancer. Red flags to consider, again, we don't really have great consensus guidelines. We have some guidelines, and things like early age of onset, bilaterality, multifocal, strong family history, or other specific histology may guide you. Now, it's been really we've had crappy guidelines previously. We have the American College of Medical Genetics. We've had AUA guidelines, and it's really been really poor. And we tried to come up with a consensus conference a couple years ago where we try to kind of get everyone's thoughts and came up with this publication. And then there's been some new updates. So Maria's done a great job with, the NCCN guidelines led by Dr. Motzer and Yonesh really saw the need for this. So we have updated the past 2 years hereditary guidelines, and the AUA has adopted it. I will tell you, we just had a second genetic consensus conference, and we have had, some consensus on some other areas. Hong has a paper looking at early onset. If you have only clear cell and you're aged like 43, the incidence of finding a germline mutation there is actually 0% in that series. So, this is a living document, and we'll continue to get more guidelines. But it's not going to be like prostate or pancreatic cancer. Pancreatic cancer, you test all. prostate cancer, we have guidelines, risk groups, those are your test. Kidney is going to be kind of, really needing to do a pedigree and figure things out. Finally, just quickly, one of the reasons why it's important, we have a new drug for VHL. VHL is a condition which is, 1 in 25,000. It's very penetrant. 90% of our patients have a family history. And it's very highly morbid with a lot of patients going for lots of surgeries. And the holy grail everyone's been hoping is to have medical management. And you see that it's a multi-organ condition. Everyone's familiar with the kidney cancer. Affects the eyes, the brain, the spine, the pancreas, the adrenal, the kidney, and also the reproductive organs. And this is the LightSpark study. It was a study looking at 61 patients. It was open really for a 4-month enrollment. It was amazing that they enrolled 61 patients in 4 months. And they basically gave everyone Welireg or belzutifan. It's a HIF-2 inhibitor. You lose VHL. You have upregulation of HIF-1, HIF-2, and then downstream you have upregulation of VEGF. So instead of using a TKI downstream, this is hoping to target the pathway upstream, right under VHL. And just going back, if you look, this is when patients had tumors, they were being watched, then they started therapy, and most of these patients had either stable disease or had reduction in the size. And looking at the updated series, in terms of the RECIST response, tumor shrinkage by 30%, RCC 60% response rate, pancreatic neuroendocrine 90%, and there's some complete responses. So in this patient population, you can say, hey, you can have a Whipple, or you may have a 1 in 6 chance of having a complete response to Welireg. It's a very well-tolerated drug. And this is just showing before the trial, all these patients, surgery, 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 surgery. They started on therapy, very quiet. Okay, so this is very exciting for these patients who, a lot of them can't work, they need to see so many doctors, they have so many operations they need. It's well tolerated. About 10% of patients have adverse events from grade 3 anemia. There's very few patients who have hypoxia, 1 of 61 patients. I give the drug. I have had no issue giving it. Fatigue is common. I have my patients measure their pulse oximetry, and I've had patients being able to avoid surgery, and it's been very great. It was approved in August 2021, this is an article we wrote, HIF-2 inhibition for VHL, who urology lead or follow. I would say, in specialized centers, urologists, see these patients, medical oncologists can see these patients, neuro-oncologist, endocrinologist, but it's a very well-tolerated drug, and if at your center you're seeing these patients, I feel that, all these different providers may be able to give this drug because it's so well tolerated. And we'll just skip over this because I know we're behind. Okay. Okay.
Questions later?
So I'll be shifting gears a little bit to talking about urothelial carcinoma and germline genetic considerations in that disease. I'm a medical oncologist, and I also see patients in my clinical genetics clinic. So I'll start with a case that you may see as a urologist. A 42-year-old woman presents with gross hematuria. She has imaging that shows a 4-centimeter mass in the right renal pelvis. She has surgery, and the pathology shows urothelial carcinoma. So the typical urology note says, no family history of GU malignancies, but you are very thorough. And you note that her mom had a hysterectomy for unclear reasons. She also has colon polyps. She had a grandfather that died at age 45 of colon cancer, and an uncle that died of some other type of cancer. So shifting gears a little bit, now you think about, well, what should I do with this woman? So we talked about other methods for getting genetic testing, but just the basics of what you want to get or what you see in clinic. So number one is a germline panel. This is what we've been talking about. They take a blood saliva sample, they analyze it for mutations in certain cancer genes, and you get a result. More and more I see in clinic, and you probably see too, tumor profiling. This is they take a little piece of the tumor, they sequence it, and then you get a report with all the mutations, some other information such as whether the tumor has high microsatellite instability, tumor mutation burden. You just should know what your assay is telling you. So the important question is, are you subtracting the germline? And that's easy to know because you send it the tumor plus a blood or saliva sample. If you just sent the tumor is going to reflect the tumor plus the germline. And I think Maria gave a good example of that she had that profile that had a BRCA2 mutation, but you didn't know if it was just in the tumor or also germline. And then there's this great, I'm not going to get too into details because it's confusing even for us that see this every day, but there's also cell-free DNA. Cell-free DNA can also be run matched. It can also inadvertently reveal the germline. So you just have to be careful with interpretation of results. Some companies are good and they tell you, they flag you, you know, this looks suspicious for the germline. Some companies may not. So just be aware of your assay, and you can always talk to your genetics group and they can help you with that. Some also tell you something called the VAF, which is the variant allele frequency. So if you have a heterozygous mutation, you expect it to be 50%, and that can give you a sense that this is something germline. And that's what the companies use, right? Like if they have a 50% variant allele frequency, they flag it for germline in some cases. So back to the case, you sent this woman for genetic testing because she was young with upper tract urothelial cancer, and she had a family history, and she came back with an MSH6 germline mutation, a pathogenic variant. So I'm going to spend most of the talk here talking about what you're going to see as a urologist in your urothelial cancer patients, and that's Lynch syndrome, by far the most common genetic condition in patients with bladder and upper tract cancer. So this is called, and many of the other speakers have already talked a little bit about Lynch. It used to be called HNPCC, hereditary non-polyposis cancer syndrome. That's the old term. And that really is because it's not just colon cancer. It's upper tract, it's uterine, it's stomach. So now the preferred term is, it's one of those weird that we went back to the name. Now I know most cases we're trying to go away from the name, but this honors Dr. Lynch, who described the syndrome. It is autosomal dominant. Almost all patients have a family history, right? So it's not recessive. You have a parent who has a parent, and it's rarely de novo. Unlike VHL, with about 10 to 20% of patients may be the first in the family of VHL, with Lynch syndrome, you almost always have a family history. The hallmark cancers are really colorectal and endometrial. So if you're seeing a urothelial cancer patient, really the question is not what other GU cancers are in the family. You should ask anybody with colon cancer or uterine cancer or any other cancers, but really that's what you want to ask about. Similarly, if you see a prostate patient, you really want to ask breast or ovarian cancer in the family. I don't care if you have kidney and prostate because those don't go together, but I know that's what we are all taught to ask. And really, the main evidence is that renal, pelvis, and urothelial carcinoma are linked to Lynch. And we think about 5% of UC is thought to be in the setting of Lynch syndrome. This may be an underestimate. The studies are not great, so it's really kind of a rough estimate. But again, about 5% of your upper tract patients are estimated to have Lynch syndrome. And of course, this varies. If you have an older gentleman who's had bladder cancer and then upper tract, less likely. If you have a 42-year-old with a renal pelvis tumor, that's a lot more suspicious. This is, so again, we've quoted the National Comprehensive Cancer Center Network's NCCN guidelines. That's what we use in our genetics clinic. That's what a lot of insurance companies base their reimbursement on. So this is why we're mentioning these. But these are kind of the cancer risks. So somebody who has Lynch syndrome through age 80, this is the rate of, or the risk of renal pelvis or ureter cancer. And see those. It's funny because it's, well, your risk is 2 to 28%. And the reason that is such wide variability is because the studies are not great. They're all small. So this is kind of a study. One study showed 28%, another showed 2%. There's not great evidence, and I'll go through it a little bit more. The important thing to take away from this slide is that the MSH2 positive patients are by far at the highest risk of urothelial cancer. PMS2 very low. Here you see the risk in the we don't even know exactly what the risk of the population for upper tract cancer is for many reasons. but just MSH2 should be in your mind as somebody who's very high risk. So screening for Lynch syndrome, who should you send for further assessment? So for patients who come into your clinic, I guess with any type of cancer, really colorectal and uterine cancer at early age of onset, which is roughly below age 50, should raise a red flag. If your patient has upper tract plus a personal history of colon, uterine, also other cancers like stomach, also raise a red flag and consider for further assessment. And then I think this is going to become much more prevalent in the future, whether you have a tumor assessment, your tumor is mismatch repair protein deficient on immunohistochemistry or microsatellite instability high. So this is being done more commonly. The mismatch repair staining is just an IHC stain for the proteins. They usually do it for all 4 proteins at once. MLH, these are complexes, so you're usually missing 2. So you're MLH1, PMS2 absent. That doesn't mean you have a mutation in both. They're just a complex. So if you're missing one, you miss the other. But if your tumor is mismatch repair deficient, or they do another, if you have a mutation in one of the Lynch genes, essentially you're not good at repairing DNA repeats, so you get this microsatellite instability. This is the old school way to do the test. Now you do it with NGS. But then you get in your tumor report, MSI high, MSI low. So MSI high is a hallmark of Lynch syndrome. And here's a little diagram. So you may remember, I'm not even going to go through the Amsterdam or Bethesda. I don't even know them myself. I have to go every time. But if you do MSI by NGS on your tumor, you're going to capture most of your patients with Lynch. Many of them will have this sporadically. Doesn't mean everybody with MSI high or mismatch repair has Lynch syndrome, but you're going to capture a good amount, much more than if you go by the Bethesda or Amsterdam. So say you're in clinic, your patient with upper tract or bladder cancer had tumor sequencing, and they came back with a profile that says you're MSI high. And you're reading the report. So now actually the guidelines are if you have any tumor, bladder, prostate, whatever, that is MSI high or mismatch repair deficient, that's an automatic referral to genetics for testing for Lynch syndrome. And this is the reason. So this was a paper published, came out from Sloan Kettering a few years ago, where we took thousands of patients who had MSI testing of the tumor. Then we went back to everybody who had MSI high, and we looked at the germline. And here's the chance that if you have bladder or urothelial, again, these are MSI high patients, what are the chances that you have Lynch syndrome? 38%. So very high, and it was actually the highest cancer. So if you had colorectal cancer and you were MSI high, your chances of having Lynch syndrome were 19%. So if you had endometrial cancer, MSI high, your chances of having Lynch syndrome were just 6%. And that's because there's a lot of sporadic MSI high tumors. But in bladder and urothelial, it appears to be more common to be Lynch syndrome related. So red flag, MSI high in both bladder or urothelial is sent to automatically to genetics for testing. And warn them, right? Don't say, oh, this is a test, it's important. So why don't we just screen all upper tract? And I have not read them, but I heard that the new AUA guidelines for upper tract may be advocating for universal testing of upper tract for either MSI status or mismatch repair. This is standard of care for all colorectal and uterine cancers to do one of these types of testing. So why not do it in upper tract? It's a good question. So some other people have tried to do this in small case series, and they pick up a good amount of Lynch syndrome. So for example, this case series picked up 5% were confirmed to have Lynch syndrome. But just plugging in the numbers, you have 150,000 colorectal cases, 66,000 uterine cases. You do MSI testing in all of them. That's standard of care for pathologists, and you only pick up, 3% of them have Lynch syndrome. If you did that for all upper tracts, much smaller numbers, and we think, only 6 to 10% are MSI high and 5% are going to have Lynch. So it seems cost effective to me, but maybe the AUA agrees this year. We'll see. Apparently they came out yesterday. Now, this is definitely an area where we need a lot more evidence and help from urologists who are seeing these patients. We have very poor guidelines of what to do with somebody who has never been diagnosed with urothelial cancer who has Lynch syndrome. How do they screen? This is what the NCCN says, and it's very wishy-washy because there's no evidence. So there's no clear evidence to support surveillance for urothelial cancers and Lynch, maybe considered in some. Again, the MSH2 are at high risk, especially males. Surveillance options, essentially they don't recommend anything in particular or when to start. You can do a urinalysis, maybe age 30. However, there's insufficient evidence to recommend one strategy. And there's several consensus papers, opinion papers. Some of them say screen all Lynch syndrome for urinalysis. With cytology, with CT, some say only at age 50. I think hopefully there will be a little bit more guidance from societies in the future. We personally have everybody do a urinalysis starting depending, 20s, 30s, so a yearly urinalysis. If there's blood, automatic referral to urology. Personally, if I see any MSH2 families, and they have a family history of urothelial, I refer to a urologist who's well-versed in Lynch syndrome. They do usually CT urogram, and many patients, they do cystoscopy for surveillance. If they have MSH2 in a very small family where I can't tell, if you have a strong you have no family history because you're an only child and, your parents are only children, I also sometimes consider referring those. But again, there's no guidelines of what to do or how to do it. So what about bladder cancer? Are your Lynch syndrome patients at increased risk of bladder cancer? Probably, but certainly the risk, upper tract is definitely a Lynch-associated cancer, bladder maybe. And the problem is, as urologists, you can get drop meds, you can get upper tract and then bladder in a Lynch patient. Well, it was the bladder cancer, a de novo cancer, a result of the upper tract. So there's a couple of registries showing that there is apparently some increased risk for bladder cancer with MSH2 carriers, but again, that risk is lower than for, it ends up being higher because bladder cancer is more common, but it's definitely not as strongly associated. So shifting gears a little bit about how we think as oncologists for patients with Lynch syndrome and UC. So this was a paper we did a couple of years ago, and this is just case examples in our practice, but it was a couple of Lynch patients that we observed that, this is their baseline tumors, and then they got neoadjuvant, or they were already metastatic, so they got systemic chemotherapy. They had 0 response to chemotherapy, but then they got PD-1 inhibitors, and then they had amazing responses. So this really makes oncologists think, well, should we even be giving chemo to Lynch patients with UC? Should we just start with immune therapy? And it's a good question, and it became a much more urgent question when this paper came out last year that made a huge splash in the news. This was an investigator-initiated trial that ended up in the New England Journal with 16 patients, so the results are incredible. And the results were incredible. These were patients with mismatch repair deficient, locally advanced rectal cancer. So instead of surgery, they went to PD-1 inhibitor, and they were all complete responses. So it makes you think, well, would that be the same? Could you spare a nephrourectomy in a patient with Lynch syndrome, giving them PD-1 inhibitors? So we don't know the answer. There are ongoing clinical trials. This is a very small one, given a couple of doses of ipi/nivo that was presented that showed, again, these were just a couple of doses, and then all patients went to surgery. There were at least 3 patients with Lynch syndrome who seemed to get good responses. This is ongoing. This is not standard of care yet, but we will wait and see. What about other germline variants in UC? So we looked at our own, at MSK. Again, a lot of our patients participate in the MSK impact where we do paired germline and tumor testing. Most patients consent to have their germline revealed, and they discussed this with us. So these were patients with urothelial cancer, bladder, or upper tract. We found a good % of them had a germline mutation in a cancer gene. And then a lot of these had BRCA and BRCA1 and BRCA2. These are the patients with Lynch syndrome in our cohort. And here you can see that red is upper tract, so the Lynch syndrome patients were almost all upper tract. But then what about BRCA1 and BRCA2? That was pretty high. So we looked, and actually BRCA2 came out, and we corrected because we also have a lot of patients of Ashkenazi Jewish ancestry in our center, so we corrected for the known founder mutations. And it appeared that there was a slightly increased risk of urothelial carcinoma in BRCA2 carriers. I would argue that this is still, not yet definitive. This was another study out of the Farber where they did, again, a large cohort of patients who had testing via commercial lab. They found similar results. So to be seen. Other large BRCA studies have not shown a particularly high risk of bladder cancer. That's why there's still a little bit of conflicting data, but possibly. And then kind of switching a little bit into therapy. So we know BRCA positive patients with breast, ovarian, pancreas, prostate respond very well to PARP inhibitors. How about patients with urothelial cancers and mutations in BRCA and other genes? So there's ongoing studies. These are the 3 that were first reported that are honestly showing mixed results, but what seems to be encouraging results for those with with homologous recombination defects. So even though, for example, the Bayou study tested olaparib in first-line platinum ineligible patients, there was longer PFS in the olaparib group, 5.8 months versus 1.8 months. So people are interested. They're still, again, not standard of care, so studies are ongoing to confirm this. So, in summary, Lynch syndrome is associated with increased risk of upper tract, likely bladder. And again, MSH2 mutation carriers are by far at the highest risk. We definitely need better data to guide how to screen these patients for UC. They're kind of all over the place, and guidance would be helpful for clinicians. There's possible UC increase with some germline DNA rapid damage repair mutations like BRCA2. That's still to be seen. And again, I think the future for UC will be that a lot of people get tumor testing, and then therapy will probably depend on what the tumor shows. So if they're MSI high, they may be candidates for immunotherapy or potentially PARP inhibitors or other trials.
Thank you, Marie. And now our last section today will be about genetic and genomic evaluation of patients with prostate cancer. Now, for prostate cancer, there is a little bit more guideline in terms of the use of genetic evaluation. So for this talk, I will answer 4 questions. Which patient with prostate cancer should undergo genomic profiling? Which patient with prostate cancer should undergo germline genetic testing? And there is very clear guideline. How should we screen for prostate cancer in patients with germline mutation? And how should we treat prostate cancer in patients with germline mutation? So to begin, the first issue is what is the difference between germline mutation and somatic mutation? So germline mutation originate in the reproductive cell, the egg or the sperm. Patient can inherit it from one of their parents. It is hereditary. Now there is a small proportion of germline mutation that is de novo. Something happened in the egg or the sperm, before fertilizations, and that start being integrated into all diploid cells in the body. And the tissue used for testing for germline mutation is typically blood, buccal mucosa, saliva, buccal swab. Now, somatic mutation arise within the cancer, prostate, kidney, urothelial that is not in the reproductive cell. It is not hereditary. The patient cannot pass that mutation to their children. And it may be present in some or all of the cancer cell. And you test for that with cancer tissue at the primary or metastatic tissues. And in the context of prostate cancer, germline mutation can predict risk of cancer development. Somatic mutation cannot. Germline and somatic mutation can guide treatment approach, and both can define cancer prognosis. There are a number of clinical genomic and genetic tests used in prostate cancer, and Dr. Carlo touched on this in her talk. So first is the germline genetic testing. And this look for inherited cancer syndrome. There are a number of testing companies that you can use: Invitae, Myriad, GeneDx, Color. They look for mutation in cancer susceptibility genes, and they can also be used to determine the use of PARP inhibitor immunotherapy or even clinical trial in advanced stages. They guide cancer screening and prevention, and they can lead to cascade testing. Tumor genomic profiling look specifically for alteration in the prostate tumor itself. There's tumor DNA sequencing versus gene expression analysis. Tumor DNA sequencing include things like Foundation Medicine and Caris, and a lot of these tumor sequencing does not do pair germline testing. So if a patient have a mutation on tumor testing, you cannot tell if it belongs to the patient or it belongs to the cancer. But they can be used to guide systemic therapy for gene expression analysis. This is probably used a lot by urologists in decision to decide whether to biopsy, whether to treat. And it's used for risk stratification for clinically localized disease. It can be used as prognostic biomarker to predict distant metastasis, prostate cancer, specific mortality, or adverse pathology. So to illustrate the point of, a mutation may be tumor or germline, when I was a fellow at Memorial, we looked at over 18,000 patients with prostate cancer who underwent pair prostate normal sequencing. And we asked ourselves, if a tumor is found, what is it likely to be? Which gene should we prioritize for confirmatory germline testing? And as you can see, TP53 and PTEN are very common in men with prostate cancer, as high as almost 30%. But the majority of them, if not all of them, are actually somatic. It's a rise from the prostate cancer. Now, there are genes like BRCA2, BALB2, BRCA1, that there are higher likelihood of germline variant. I believe BRCA2 was almost 60, or BRCA1 actually is almost 60% in the germline. And then there's some of them that are actually both germline and somatic. So the point here is that, there's really no way to know, and the only way to confirm is to do germline genetic testing. Now, I'm sure you have heard about these genes that are moderate penetrance, high penetrance, low penetrance. What does that all mean? So that refers to the cancer predisposition risk compared to people without a germline mutation. So first is the high penetrance gene. These are quite rare, but when the patient have it, they have much higher risk of cancer development, greater than 5 times the risk of someone without a mutation. And these are your typical P53 Li-Fraumeni syndrome, BRCA1, BRCA2 mutation. The moderate penetrant genes are the ATM, the CHEK2, that when you send a patient for sequencing, sometimes you can incidentally find these mutations. That's not necessarily the causative mutation in the patient cancer development, but they confer about 2 to 4%, 2 to 4 times the risk of cancer development compared to someone without a mutation. And one thing that probably need to be updated is that the BALB2 here is actually, a lot of people would argue that they actually are high penetrant genes, and they no longer moderate penetrance based on what we know. And lastly, there is the low penetrance genes that can also refer to the things like single nucleotide polymorphism, where probably 1 in 5 of us here in the room carried it, and it have a lower risk of cancer, slightly increased, but still low. So most utility in germline genetic testing is in identifying the moderate and high penetrance genes, and the utility of testing for low penetrance mutations is debatable at this point. So now, so this is a question for the audience, and I don't have the answer system, so maybe just a raise of hand. A 70-year-old man with metastatic prostate cancer had tumor sequencing of his metastatic rectoperitoneal lymph node. The test reports showed that a PRCA2 pathogenic variant was found without knowing more, which is the best description of this variant. A, germline mutation. Anyone? B, somatic mutation. C, this mutation may be germline or somatic in the origin. And D, this mutation is both germline and somatic since it's found in the metastatic lesion. So that is actually the answer. So the answer is C. This may be germline or somatic. We don't know. We need confirmatory germline testing. So now, who to test? The criteria for germline testing can be based on prostate cancer alone without knowing anything about the patient's personal or family histories. And one of that is patient with localized high risk or very high risk prostate cancer. So what do I mean? So high risk patients are those with cancer spread beyond the prostate with extracapsular extension, bladder neck invasion, seminal vesicle invasions are those with grade group 4 or grade group 5 prostate cancer, so total Gleason 8 or higher. And then in the NCCN guideline, they also include the PSA level of greater than 20. Now, as urologists, we know that there are patients with humongous prostate, with high PSA and low Gleason 6, Gleason 6 cancer. And, you may argue that those patients are not technically high risk, but they are by PSA level. And high risk is, the additional other features. Every patient with no positive disease, we see some of these patients now with increasing use of PSMA scan or metastatic prostate cancer need to undergo germline genetic evaluation because the frequency of germline mutation in this patient population is very high, and we'll talk about the specific proportion later. And in addition to germline testing, they also qualify based on the NCCN guideline for tumor somatic testing. But per the NCCN guideline, metastatic biopsies is preferred over primary tumor sequencing. And the point for this is to look for DNA repair genes, microsatellite stability, and mismatch repair deficiency to guide additional systemic therapy. Now, beyond that, if patient doesn't meet criteria based on prostate cancer alone, the guideline is to perform a detailed personal history. Obviously, any man with a history of breast cancer really raise suspicions for BRCA mutations, and they need to be referred for genetic evaluations. Others include history of pancreatic cancer, colorectal cancer, gastric cancer, upper tract urothelial carcinoma, glioblastoma, biliary tract, and small intestinal cancer. So pretty much looking for the Lynch syndrome or hereditary breast and ovarian cancer syndrome. And family history, Ashkenazi Jewish ancestry and history of prostate cancer meet the guideline for referral. Known family history of familial cancer risk, such as these genes highlight here. If a patient have a father or brother with prostate cancer diagnosed before the age of 60, they meet referral criteria. So if a patient, 50-year-old gentleman with prostate cancer and reported father with family history of father with cancer diagnosed at 50, that patient actually do meet referral criteria as well. A multiple family member with the history of prostate cancer or regional metastatic disease. and greater than 3 cancer on the same side of the family, especially diagnosed earlier than age 50. So what genetic test to order? So this figure I like because it kind of showcase the heterogeneity and the different genetic tests available. Now, this was back in 2020. I think a lot of the panel tests now include much more than, lab number 5 or lab number 9, right? Very few labs include 4 or 5 genes anymore. But the point is that the germline multi-gene panel testing should at least include BRCA1/2 mutation, ATM, BAL-B2, CHEK2, HOXP13, and the Lynch syndrome genes with our MLH1, MSS2, MSS6, and PMS2. Now, these are not all the genes that need to be included. If there's additional family history suspicious for other hereditary cancer syndrome, that need to be included as well. And this is a table that shows the prevalence of germline mutation in different prostate cancer population. So the first column are the general populations, and even in patients without cancer diagnosis, there was about 2 to 3% with germline mutations. And I actually summarized this in a easier to read format. So no cancer diagnosis is about 2.7%. Low intermediate risk prostate cancer have been reported to be as high as 4 to 5%. High risk localized prostate cancer is 5 to 9%, and no positive or metastatic prostate cancer, we're looking at 12 to 17% with germline mutation. What are the features of hereditary prostate cancer? So these patients, we're going to go through some of these data. A patient with a BRCA1 or BRCA2 have higher risk of developing prostate cancer. The risk is higher in BRCA2 than BRCA1 carrier. They tend to have early onset prostate cancer. They tend to have aggressive phenotype, Gleason 8 or higher at the time of diagnosis, more advanced disease. And in the setting of primary treatment, they tend to have lower cancer-specific survival. So then that brings us to how to screen for prostate cancer in patients with germline mutation. Per the NCCN guideline, for men with personal history of pathogenic variant in prostate cancer associated risk genes, and I list those on the side there, but particularly BRCA2 mutation begins screening at age 40. And screening include annual PSA and DRE. And we typically talk about, in average age man, the PSA cutoff is 4, but for men with BRCA1 and 2 carrier, the PSA cutoff should be lower. And then there's the issue of, do you stop screening at age 75 unless patient is very healthy with little comorbidities. And in addition to PSA and DRE, the guideline strongly recommend integration of multiparametric MRI in the screening of patients with germline variants for prostate cancer. Now we move on to the issue of how to treat patients with prostate cancer and a germline mutation. So in the setting of localized prostate cancer, so this is a study out of Johns Hopkins for men with BRCA1/2 mutation or ATM who elected active surveillance. They have higher risk of Gleason upgrading on active surveillance, and the risk is particularly higher in BRCA2 patient. And in the localized setting, this is a study on men with localized prostate cancer who underwent definitive treatment with surgery or radiation with a BRCA mutation. They tend to have worse metastasis-free survival compared to men without the germline mutation. They have worse cancer-specific survival. However, there is currently no guideline recommendation for management of localized prostate cancer in men with BRCA mutation. I think it's generally safe to say that in men with BRCA mutation with low-risk prostate cancer who elect for active surveillance, perhaps in this patient, I would do closer follow-up and, lower trigger for definitive treatment if there's progressions of cancer volume or Gleason upgrading. The role of germline testing in management in men with localized prostate cancer is unclear. There is low prevalence of germline mutation, and there's the management strategy in this setting is not well defined. Now, unlike localized prostate cancer, in advanced prostate cancer patients with germline mutation, there are better treatment guideline, and the point is that we want to move the treatment of these patients from a traditional, one-size-fits-all approach to precision medicine, where we can select for therapy based on the patient genotype. And there are two categories of therapy that are available for patients with metastatic castration-resistant prostate cancer. First are those with DNA repair gene mutations, and they qualify for BOP inhibitor. Now for olaparib, the indication is a little bit more broad. It's BRCA1/2, ATM, BALB2, CHEK2, FANCA, and RAD51D. For rucaparib, it's only for patients with BRCA1/2 mutation and ATM. And Dr. Carlo touched on pembrolizumab or immunotherapy before, and that is patient with mismatch repair deficient prostate cancer or microsatellite unstable cancer qualify for immunotherapy in addition to tumor mutation burden. Now, it's important to know that it is not the Lynch syndrome diagnosis. It is the tumor phenotype that qualify patient for immunotherapy. Sorry, going back here. So in conclusions, the genetic and genomic profiling is the standard of care in patient in the management of patients with prostate cancer. The most important prostate cancer susceptibility genes are BRCA2, BRCA1, BALB2, HOXB13, ATM, and CHEK2. Patients across the spectrum of prostate cancer qualify for genetic evaluation, and I hope by now you've been convinced that the implications for these patients are pretty clear in terms of cancer surveillance, treatment, and family counseling. And patients qualify for germline genetic testing regardless of personal or family history are those with high-risk localized prostate cancer, node positive, and metastatic disease. And it's especially important in the localized patient because those are the patients that urologists see, and we are the gateway to their genetic evaluation. And precision therapy are now approved in the care of prostate cancer patients. So, that genetic evaluation is so important. And I think we actually finished ahead of time. We'll take any question that you have.
Very nice series of talks. I have a question about Decipher and whether that can give us any insight as to whether there may be some underlying germline mutations.
So the Decipher test is a combination of genes, and as far as I know, there is no. They don't report the individual mutations on the Decipher test. They give you a score, right? And that
doesn't give you any hint as to whether they're a BRCA.
No.
It's just transcriptomic, looking at a bunch of genes. So it's not like a looking for the HR defect, BRCA1, BRCA2. They're not like on that panel. It's just looking at the aggressivity.
Yeah,
right, because they usually order for patients with intermediate risk disease. They're not going to get full genomic evaluation. But I was just curious if that could help.
Yeah.
I have one other question about the Grail cells, a test called Gallery, which can potentially check for cell-free DNA that could be reflective of underlying cancer, and I think 5 or 6 major types. Just curious as to what the current thought on that is. It seems pretty exciting.
I mean, it's about $1,000 a test, and I don't think it's really reimbursed. It is exciting, but there are some tumor types, like kidney doesn't shed at all. Even in like a lot of metastatic patients, you don't see it. But they're actively researching. We're actually looking at it with the company in some of our hereditary patients. We're actually looking at it to see if it would predict like an HLRCC and SDH, but I don't know about in BRCA or the other ones.
Yeah, no, I don't think that they. I think that there was an interesting New York Times article about the use of GRAIL testing for cancer screening, and I don't know if it's ready for being used in a clinical setting yet.
I mean, they're putting millions and millions of dollars. I mean, it's better than nothing, but I don't know if it's ready for prime time yet.
Right, right.
Do
Okay.
you use it, Dr. Smith?
I've never used it, but I've had a few people, friends of mine, have asked me about it. And, honestly, I looked at some of the data, and it looks promising. I mean, it seems to be picking up cancers at a time that they need to be treated, but not too late.
I mean, I do worry about like kidney cancer. We're going to find like 1 centimeter renal masses, and we're going to be over-treating. I mean, the jury's still out, but they are marketing it to primary care doctors, and I've had a lot of primary care doctors say, I ordered this test and I don't know what to do with it. Do you want to image them? And I kind of don't know what to do.
Yeah. Well, I mean, I guess it's quite the holy grail, right? What
Yeah.
they're looking for. So, interesting. Well, thank you.
Thank you.
Thank you. I was just curious what you guys' spiel is when you talk to patients about genetic testing. Like, what do you say to them if you're seeing somebody you want to get genetic testing on or refer them?
Well, yeah, go ahead, Brian.
I mean, I try to explain to them, we don't know why you developed this cancer. It could be just due to bad luck. It could be, environmental, or you could have something which predisposed this to, you to develop this. And you might be at risk of developing other cancers, and your family may be at risk of developing other cancers. And you could, not look into it, but a big problem usually starts as a little problem. And we'd like to find that little problem early by looking at your genes. And I think when you explain it like that, most patients are willing to take a look at it. Obviously, some patients don't want to be bothered, but when you tell them that it also, for prostate or kidney or bladder, it might affect that they might be treated differently and might have better outcomes, it's an easy sell.
Yeah, for me, I have been referring a lot of patients with prostate cancer to Dr. Baker, and what I say is that this information will give us some insight into the etiology of their cancer. A lot of patients, when they develop cancer diagnosis, they want to know why did they develop this cancer. And that's when I start introducing the idea of genetic evaluation, where one way to find out why, maybe to look into your gene and see if there's any gene that may predispose you to cancer development. Then I also talk about, in localized cancer, this information may not be important at this point yet, but if it ever get to a point where you need additional therapy, this gives us additional tool in our toolbox to fight cancer if we need that information. I also talk in young patients, I talk to them about, surviving cancer and the risk of developing an additional cancer diagnosis if they have a germline mutation, and if they have in people with children. I talk with them about this information is not necessarily just important for you, but they're also important for your children, your grandchildren. So, for instance, a 75-year-old, 80-year-old man with metastatic prostate cancer, they may say, why do I care? This is where I'm at. But, it have implication for your family member that they, even though they don't have cancer diagnosis yet, they may qualify for additional testing. It's interesting because sometimes I have men come in with their family member, their niece, their nephew, their children, and they was like, no, I think I'm good. And the family member was like, you should get testing because we need to know,
I'd also just point out that in urology, we have a unique situation. Men like to put their head in the sand. And if you look at rates of testing for like colorectal cancer, it's not balanced. The patients who make it to like Dr. Baker, they're more likely to be women. And men and women both are at risk of colorectal cancer. So, we have, had this system where they're captive in our clinic. telehealth genetic counseling set up, point of care blood. But if you look at it, national rates for men who are referred, a lot of them don't follow up on it. So now as we're moving out, we're actually having the clinic coordinator, we have a list, and they're calling them 3 times to follow up on it because, again, a lot of these patients wouldn't make it to the genetic counselor if they're, but again, if you get their children to hound them, then I think there's a higher likelihood of success.
Mm-hmm. Do you guys talk to them about in life insurance, stuff like that, and cost of the testing, or you just kind of defer to that counselor?
For me, I don't, because I have the benefit of having Dr. Baker and her genetic team talk to them, and I figured out, because I actually don't order the genetic test either, I refer them to Dr. Baker and see them pretty quickly. Right.
There still are a lot of misperceptions about the cost of genetic testing, the potential for genetic discrimination. So at the very least, we need to dispel those misperceptions because that could be the barrier that would prevent a patient from moving forward. And I will say many times it is the children that prompt an individual to move forward. And they'll even say during a counseling session, as we're trying to determine whether they want to move forward with testing, well, it's for my children, really, that I want to do this testing. And I'll explain to them, but there actually are some personal benefits as well. If we find a BRCA2 mutation, for example, and I'm meeting with a 65-year-old female who still has her ovaries and her tubes, it could have implications. Many times a patient with breast cancer will say, well, I've already had cancer, so what do I need to do this testing for? I know I already, I only want breast conserving surgery. I don't want to do a bilateral. I don't need this genetic information. But, we could cure her of her breast cancer, but if she develops an ovarian cancer that we didn't have a heads up about, or could do something different to prevent it from happening. And when you look at pathology specimens in women who undergo risk-reducing salpingo-oophorectomy, a small percentage of them have occult fallopian tube cancer where we believe most of the ovarian cancer originates. And literally, we all have patients where they've literally rewritten their future because they embraced the technology and they met with someone to decide what I should do based on those positive test results, and they literally changed their course.
I'd say for Gina, I used to test on my own. I spent 5 years with genetic counselors in a joint clinic. So when I got to UCLA and I didn't have that resource, I had a patient, let's say, with HLRCC suspicion. I'd make them watch. There's a series of videos like on Invitae's website, and I would just document it. If you're not documenting that you're doing the whole process, I think you're at risk. And there's some patients who, if they got tested and they at like 38 and they try to apply for life insurance, they could probably sue you if they didn't really show that there was like informed consent. I do think these telehealth companies are going to expand access, so you don't have to hire your own genetic counselor to be in clinic with you. And if you don't have not an academic center, getting a genetic counselor could be challenging. But these companies, there's people licensed in every single state. And it's very hard for us to recruit academic genetic counselors because they can be in their own home and they could be like wearing their underwear doing a counseling session, and they get paid more by a lot of these companies. Yeah.
That's great. Thank you.
Yeah.
Hi, I have a few comments and questions. I am from Mexico City, and I wanted to ask you something that we have found after the pandemic and the confinement. Mexico is a country with very little incidence of prostate cancer. Every time we came here to the AUA, this is my 33rd meeting here in the AUA, and I remember all this through these years. They were telling all the incidences and everything. Mexico was very low. We didn't have too much radical prostatectomies as we have now. After the pandemic and the confinement, we have found in our offices, in mine at least, that PSAs, some patients that were normal 1 year, the next one, there were from 350. For us to see a patient with 22 of PSA, they were just spread all over. 350 in a year and 700 in a year, it's been out of range for us. We've seen patients with 3,500 of PSA. So first, this is the first question, is have you seen something like that in your experience, in your practice? You've heard something that these PSAs are rising so high and so fast?
I mean, that I seen. I mean, I think here in patients who usually the PSA that's that high are those without a cancer diagnosis. I haven't seen someone who's actually in urology clinic who we managing them either active surveillance or definitive treatment. That all of a sudden they just jump that quickly. I personally haven't seen them. I have seen patients who come in with initial diagnosis of prostate cancer, de novo, who have that high PSA, but Brian.
Yeah, I mean, I do think we'll see, looking back, 10 years from now, we'll see that the pandemic, where we had 2 or 3 years of people not going to the doctor, there's probably a higher rate of more aggressive cancer. And also, living a sedentary lifestyle and having unhealthy, food choices, also predisposes risk. So I'm sure that there's a lot of different factors which could be making patients present at a more aggressive or more advanced disease that are, environmental, that may not be genetic.
Yeah, that's my next question, is that epigenetics and environment, does it have something to do? We have more pollution, different kind of pollution, and we're also having a pollution of, I call light. We are more exposed to light for more hours than I believe we should, and many other things. So you think also, I have a question of these new vaccines that we all have worldwide. Does these vaccines, new vaccines without testing and all these things, you think it might have something to do with what we're looking at?
I know when patients will mention to me, some exposure history that they had, I'll never dismiss that per se, but I'll mention that, we are a combination of our genes and our environment and lifestyle habits. And there's an expression, genetics loads the gun, environment pulls the trigger. You take something like HIV, which initially we would think is completely due to exposure history. But yet, studies have shown that there are individuals that have certain variants in their genes that can be exposed again and again and are less likely to become infected. So everything, I think it's on a continuum. Everything has different amounts of genetic and environmental contributions, some more, some less.
Okay.
I mean, there are a lot of things that we just don't know, and over time, I mean, now we're learning, I would tell you, I've seen a lot of men who are like 30-year-old vets that have been exposed to burn pits in like Iraq and Afghanistan, and they've presented with horrible kidney cancers, and they get genetic testing. So I mean, it might be some susceptibility genes that we just don't know, but, again, it is probably multifactorial. There are, even though, we're telling you today about the monogenic conditions, but I think we'll be moving more towards polygenic risk scores. They have that for prostate cancer. Very soon, I think we'll have that for kidney cancer when they're doing like 10,000 case control series looking for SNPs. There's going to be more complicated. I'm sure there's an interplay between, the genetics and the environment. We're just not very smart. We think we are, but we're not. Yeah.
And lastly, we had in Mexico lutetium approved since 2018. I know in the US it just became available for metastatic cancer. I sent a paper for these years here at the AUA. It was out of the program, but what we're doing since 2018 is that after a localized cancer, after radical prostatectomy with a robotic prostatectomy with a Da Vinci system, we're giving a prophylactic dose a month and a half after the surgery. Since 2018 to this date, we have no recurrence rate, 0. Have you heard something about it? Because I haven't read anything about it. And this paper was not this year, I don't know why. Because to use lutetium as a prophylactic, I haven't heard it. And we based that the use of the lutetium, because every time there were papers in the 90s that when you were performing the radical prostatectomy, that those were open before even laparoscopy. Those samples of the blood were found to have some neoplastic cells, prostate cells. So that's why we decided to go for a prophylactic after the radical prostatectomy with the Da Vinci when we had it. And so far we haven't had any recurrence. None of our patients is with any other medication so far. And PSAs are 0.3, 0.005, things like that. What do you think of what we're doing? That now
I mean,
that
it sounds exciting. If it's done on trial, I think it's something where be very thought-provoking. But I know in the U.S. we can't just prescribe it without. It's very restricted. I mean, the Novartis and Telix have approved. Novartis and Telix have PSMA agents, but I think only Novartis has the approved lutetium, and Telix has one which will probably be approved in the near future. But these are, I think, beta emitters, and if you can see the tumor on the PSMA or soon the zirconium PET CT and kidney cancer, then you can have something home to that and treat it, and it should be able to identify micrometastatic sites as well.
Okay. Yes, this is the very last thing. Sorry, guys. We give a physics course applied to urology every year. We've done about 20 of those in Mexico, and we invite people from NASA and other institutes from astrophysics and things like that. And I have asked them, now I'm asking you, all these things that are happening, radiation and things like that, you think this might be influencing all these changes and mutations in the genes and stuff? And if so, how could all mankind be protected?
I mean, even probably you flying here probably gave you a lot of radiation dose. So we appreciate you taking that risk to fly here. But the airline pilots, there's a lot more radiation, but it's not that. The risk, I don't think, is that substantial. But we do know, even in doctors who are interventional radiologists, the risk of glioblastoma is higher. So, radiation does impact. We do know, obviously, acute radiation, like survivors of Hiroshima, they have a much higher rate of certain cancers. But, when you look at certain risks, I worked, before I went to medical school, I worked in a geochemistry lab. People were doing uranium dating, and the average age of those people were in their 50s, where they died because they were exposed to high levels of radiation. So it's definitely, I'm sure with the ozone layer decreasing, there's probably more radiation going, and I'm sure it's impacting rates of cancer.
Okay, that was it. Thank you very much.